Hi friends, today we are going to discuss about the important topic carcinoid heart disease. Myself Dr. Anand, Assistant Professor in DM Cardiology at UNMICRC Institute of Cardiology and Research Center and BJ Medical College, Ahmedabad. So, introduction, tricuspid regurgitation and tricuspid regurgitation and pulmonary regurgitation caused by dilatation of the valve ring secondary to RV failure or pulmonary hypertension, respectively. Primary disease of tricuspid valve and pulmonary valve are uncommon. Common causes of tricuspid regurgitation and pulmonary regurgitation are congenital abnormalities, rheumatic heart disease, and infective endocarditis. But rarely, carcinoid heart disease is a rare but interesting and important cause of tricuspid valve and pulmonary valve disease. Neuroendocrine tumors are a rare group of neoplasms. Incidence rate is up to 5 cases per 1 lakh per population. Mostly, they are from the GI tract, nearly 90% of the cases. Indolent for many years, symptomatic when large enough or when they metastasize to the liver, mostly. Or there may be other organs like lungs and bones, etc. Nearly 30 to 40% of neuroendothelial tumors develop carcinoid syndrome, mostly with liver metastasis. 20 to 50% of carcinoid syndromes are diagnosed with carcinoid heart disease. Carcinoid heart disease is also called as Hedinger disease or syndrome. Outcomes without treatment are poor. 3-year survival is nearly only 31% versus with treatment it can be improved to 68% and without carcinoid heart disease. Pathophysiology. Valve interstitial cells are the most abundant cells in the heart valves, found dispersed throughout the 3 layers. In the picture, we can see fibrosa, collagen, spongiosa, proteoglycans, and ventricular or atrial layer elastin and abundant valvular interstitial cells. In diseased valve interstitial cells regulate repair and valve remodeling. Valve interstitial cells associated with the inflammatory cells, neovascularization, increased matrix production, and eventually fibrosis and calcification. Neuroendothelial tumors secrete a range of vasoactive substances, including 5-hydroxytryptamine, that is serotonin, prostaglandins, bradykinin, histamine, and substance P. Serotonin analogs like serotonin undergoes degradation in the liver by hepatic monoamine oxidase. Symptoms do not develop until metastasis to the liver has significantly impaired the hepatic function, that is, decreased levels of monoamine oxidase in liver. Enzymatic inactivation of serotonin by pulmonary monoamine oxidase in the lungs vasculature protect the left-sided valve, that is left-sided cardiac structures. Rarely, primary ovarian carcinoid tumors can also cause carcinoid heart disease in which ovarian vein bypass the liver and porous circulation. Serotonin. The long-standing exposure to the high serum serotonin concentration is one of the crucial factors. Serotonin receptor type 5-HT2B is the most abundant in the heart. Stimulation of 5-hydroxytryptamine 2B increases the mitogenic activity of the cardiomyocyte and fibroblast, cytokine recruitment, and upregulation of TGF-beta. We can see in the picture, that is 5-hydroxytryptamine acting on 5-HT2B receptors, which ultimately leads to the increased intracellular calcium levels, inflammatory process, mitosis, infiltration, increased levels of platelet-derived growth factors, which ultimately leads to the endocardial plaques. We can see in the picture white plaques like deposits on the endocardial surface of the heart, structures with the valve leaflets and subvalvular apparatus thickening. We can see here the fused and shortened chordae and thickened papillae muscles. In the vast majority, nearly 90% deposits are found in the right heart. Hence, tricuspid valve and pulmonary valve involvement is very common. Left heart involvement occur in cases of extensive liver metastasis, bronchial carcinoids, and patent foramen ovale, nearly 1/3 of the cases. Clinical presentation. In carcinoid syndrome, between 5th to 7th decade, that is nearly mean age of 55 to 60 years, the clinical presentation like bronchospasm, cyanosis, diarrhea, cramping, flushing and hypotension, pellagra, and telangiectasias. Onset of carcinoid syndrome symptoms to diagnosis of carcinoid heart disease is nearly 2 years, which may be up to the 5 years. 50% of the subjects with moderate to severe tricuspid insufficiency may be asymptomatic or present with slight symptoms. Moreover, 1/3 of these subjects may not present with any systolic murmur. Most patients present with the signs of the right heart failure secondary to the tricuspid valve and pulmonary valve dysfunction. Peripheral edema, ascites, pleural effusion may not be the heart failure. Also associated with liver insufficiency, malnutrition, and venous obstruction of the tumor. Labile BP, pronounced hypotension or hypertension depending on the relative quantities of individual vasoactive substances. In case series, 97% of the tricuspid valve disease, of which 90% had moderate to severe tricuspid regurgitation, few had a coexistent tricuspid stenosis. Pulmonary valve diseases, in 88% of the cases, of which 81% had a pulmonary regurgitation and 53% have pulmonary stenosis. Only 7% had a left-sided heart involvement, typically mild to moderate mitral regurgitation. Cardiac metastases of carcinoid tumors are extremely rare. In the largest series of 11 patients, all metastases were intramyocardial. Serotonin has a vasospastic effect on predisposed atherosclerotic coronary arteries. The spasm displays a biphasic dose-dependent result causing vasoconstriction of the diseased coronary arteries and dilatation of the normal vessels. This is a kind of biphasic kind of response, that is vasodilatation in normal vessels but vasoconstriction in diseased coronary arteries. Coronary vasospastic effect can manifest clinically as variant, that is prismatic angina with chest pain at rest in the absence of occlusion of coronary lesions. Nowadays, we can see some patients with MI-like symptoms, that is myocardial infarction, which angiography normal, but somehow diagnosed as a prismatic angina. That is, raised level of serotonin, Carcinoid syndrome is one of the cause for that. Biomarkers: 24-hour urine levels of 5-hydroxyindoleacetic acid, that is more than 300 millimoles, that is increased risk of carcinoid heart disease. False positive test: tryptophan-rich products and drugs can lead to the false positive test. Every 10 minutes increase in the 5-hydroxyindoleacetic acid levels leads to 11.8% increase in 12-month mortality. Another test like chromogranin A, which has sensitivity up to 100% and specificity nearly 30% in advanced carcinoid heart disease. Chromogranin A used for neuroendothelial tumors, relapse or progression, not recommended as a screening test for carcinoid heart disease. Activin A has a high sensitivity of 87% and low specificity of 57% in carcinoid heart disease. We can see in 4-chamber view in 2D echo, like right-sided structures are involved, which leads to the dilatation of the right atria, and we can see here the affecting the tricuspid valve, there are thickened leaflets of the tricuspid valves. We can see on Doppler there is tricuspid regurgitation and somehow tricuspid stenosis. And tricuspid jet is also we can see in the lower side. Echocardiographic features: tricuspid valve, thickening of the valve leaflets and subvalvular apparatus, diminished normal concave curvature of the leaflets, altered dynamic motion of the leaflets during diastole, fused or shortened chordae retraction and reduced excursion of valve leaflets, tricuspid regurgitation ranging from mild to a severe levels, sometimes with a coexisting stenosis. We can see here, like tricuspid valve, here pulmonary valve. We can see in a B diagram, that is in B view, the pulmonary stenosis with pulmonary regurgitation. Pulmonary valves appears somewhat thickened, and there also we can see in right lower side there is a regurgitation of the pulmonary valves, that is PR, pulmonary regurgitation. Echocardiographic features: pulmonary valve, diffuse thickened valve cusp, straightening of the cusp, fixed, retracted at thickened cusp, and pulmonary regurgitation and stenosis. Somehow, in some cases, the left-sided heart involvement can also occur. We have seen previously in bronchial carcinoids, in case of patient with carcinoid syndrome and patent foramen oval, left-sided cardiac structure involvement can be seen. We can see in parasternal long axis view, that is thickening of the mitral valves, and non-coronary cusp of aortic valve involvement can also be seen. Echocardiographic features: mitral valve, diffuse thickening of the valve leaflets, thickening of papillae muscles and shortened chordae, restricted leaflet mobility and tenting of the leaflets, and mitral regurgitation. Right ventricle involvement like dilatation of the chamber and impaired function of the right side of the heart. Imaging modalities: cardiac MRI for pulmonary valve assessment, cardiac metastasis, and for verifying the RV size and function, cardiac CT, valve pathology, RV status, and pre-op CT-Sca needed. Somatostatin PET CT for carcinoid heart disease assessment. Cardiac CT 4-chamber view demonstrates the thickening and shortened tricuspid valve leaflets. We can see in A image of the thickening of the tricuspid valve leaflets, which ultimately there leads to a dilatation of the right ventricle and right atrium. Moving of the interventricular septum towards the left side of the heart due to chronic volume overload can be seen. Treatment: there are mainly 3 elements of carcinoid heart disease treatment. That is, first, heart failure therapy, intensive lowering of the 5-hydroxy-indole acetic acid value below the level of 300 ml per 24 hours. Cardiac valve surgery. Pharmacotherapy, heart failure therapy like thiazide and loop diuretics can be used. No evidence of benefit with AC inhibitors and ARB or beta blockers. Somatostatin analog like octreotide and lanreotide are the mainstay of treatment in carcinoid syndrome. No data to suggest that these either cause regression or prevent progression of carcinoid heart disease. No evidence of improvement in survival in carcinoid heart disease. Escalation therapy, peptide receptide radionucleotide, that is erythroid and ludotatide, interferon alpha, everolimus and pasireotide, temozolomide and capecitabine chemotherapy can also be used. Non-cardiac interventions like transcatheter arterial embolization, decreasing the tumor burden and hormone levels, liver cytoreactive surgery. Nutrition, optimizing the patient for the surgery. Higher prevalence of malnutrition leads to poorer outcomes and reduced survival. Instability in carcinoid syndrome or an active metabolic state would be a reason accepted for delay in cardiothoracic surgery. Protein target must be around 1 to 1.5 grams per kg per day for dealing with malnutrition. Cardiac surgery. Valve replacement at 2 years, the survival is nearly 40% compared to 8% in a subject with an advanced symptomatic carcinoid heart disease managed without surgery. We can see a difference of 40% versus 8% in patients without treated by surgery. Tricuspid valve insufficiency is the most common abnormality. Carcinoid heart disease usually die as a result of severe tricuspid regurgitation rather than the carcinomatosis. Therefore, valve surgery should be considered even in metastatic diseases. Cardiac surgery. Given that it takes nearly 6 to 12 weeks to recover from the cardiac surgery, they should have life expectancy of at least 12 months. There are various studies given by different authors which can tell us about the 30-day, 1 year and 5 year survival after surgery for carcinoid syndrome. In RVOT obstruction, that is right ventricular outflow tract obstruction, and in pulmonary valve insufficiency, pulmonary valve replacement and RVOT enlargement with a patch can be done. Despite some patients having relatively mild pulmonary valve disease, pulmonary valve replacement in addition to a tricuspid valve replacement has been shown to reduce the RV size after surgery as compared with the patient with isolated tricuspid valve replacement. Bioprosthetic valves are preferred because elevated bleeding is associated with the extensive liver diseases and hepatic malfunction. So, bioprosthetic valves are more commonly preferred than metallic valves. Moreover, the increased probability of the future invasive procedures requiring temporary withdrawal of anticoagulants. Also, right-sided bioprosthetic valves are less prone to the thrombosis than mechanical ones. Cardiac surgery. Timing of surgery. Early or soon after the onset of the cardiac symptoms or severe carcinoid heart disease. Asymptomatic patient with a severe carcinoid heart disease, progressive ventricular dilatation and impairment of ventricular function can be considered as an adequate time for the surgery in symptomatic and asymptomatic patients. Every patient with undergoing the surgery for carcinoid heart disease should be tested for patent foramen ovale. Surgery to a tricuspid valve can damage the ventricular cardiac conduction system. Subsequently, PPI through functioning tricuspid valve replacement is a disaster in carcinoid heart disease patient. That is, subsequently permanent pacemaker implantation through a functioning tricuspid valve replacement is a disaster in carcinoid heart disease patients. Percutaneous intervention. In a patient not suitable for a cardiac valve surgery, use of balloon valvuloplasty can be reported. Identification of the patient with a predominantly stenotic lesions will be problematic in the most patients, also a significant valvular regurgitation. Some reports have shown functional and hemodynamic benefit. Others have noted either lack of symptomatic benefit or rapid relapse of the symptoms and valve stenosis when the initial benefit did occur. Carcinoid crisis. Carcinoid crisis is a life-threatening complication in subject with the carcinoid syndrome undergoing surgery, as well as when exposed to the anesthetic drugs or other medicine like vasopressor and opioids. Carcinoid crisis is evoked by the release of substances with a biological activity which can cause hypotension, tachycardia, arrhythmia, flushing, wheezing, as well as symptoms from central neurological system. Pre-op prevention of octreotide venous infusion and 50 to 100 mg per hour for 12 hours before surgery can be used. Infusion should be maintained throughout the operation and then therefore until the patient state stabilization. If signs and symptoms of carcinoid crisis develop like hypotension, an additional bolus of 100 to 200 mg of octreotide must be given and repeated as needed, with the simultaneous increase in octreotide infusion at the rate of 200 mg per hour. Post-surgical care, warfarin anticoagulation for 6 months depending on the risk. Lifelong aspirin 75 mg once a day. Disease recurrence reduced by controlling the carcinoid syndrome. If in need of reduced valve surgery, percutaneous valve replacement can be considered. Prognosis. The median survival in advanced carcinoid syndrome is nearly 12 to 30 months. Carcinoid heart disease with a heart failure has a median survival of 11 months without treatment, and most patients succumb within 1 year because of progressive heart failure. In analysis of 10 retrospective study with a total 193 patients with valvular surgery, largely compromising of tricuspid replacement, median post-operative survival was 5 years, with significant symptomatic relief in majority of the patient. Take-home message: carcinoid heart disease clinical presentation is often quite late. In symptomatic carcinoid heart disease, valve replacement is the only treatment that can improve the outcomes. Surgery should be always considered regardless of the metastatic disease, but perioperative risk remains significant. Optimal care is provided by close collaboration across multiple subspecialties. Thank you.